Today's lecture entails a description of the anterior abdominal wall. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this lecture. Let's begin. At the conclusion of this lecture, you should be able to describe the layers of the anterior abdominal wall, describe the muscles found that give rise to the anterior abdominal wall, describe the basic circulation and nerves of the anterior abdominal wall, and, if interested, examine the surgical incisions used to enter the anterior abdominal wall. Recall that I mentioned during the introduction that the abdominal wall has no bones per se. Then, we must ask ourselves, what provides the protection to the abdominal content, the organs responsible for digestion, etc.? Well, the answer is being shown to you. It is the anterior abdominal wall. What are the components found in this wall? Let's list them now. Skin, superficial fascia, consisting of fatty and membranous layers. We will see this in a second. The muscles, starting with the external oblique, the internal oblique, the transversus abdominis, another layer of fascia, known as the fascia transversalis, extraperitoneal fat, and finally, the peritoneum. You should be able to identify these structures, and if you ever pursue general surgery, you will remember this list in order. Let me now show you these structures as they appear in the body. The layer of skin is obvious and forms a protective layering on the outside of our bodies. Dissection starts by reflecting the skin, as has now been done in this cadaver. If only the skin is reflected, we can identify the superficial fascia. In this case, it is the fatty layer of the superficial fascia known as campers. If we now remove Camper's layer and zoom in on the anterior abdominal wall, another layer of the superficial fascia is revealed, the membranous layer known as scarpus, usually most prominent in the lower part of the anterior abdominal wall. It attaches to the deep fascia of the thigh. By the way, in case you're wondering, this individual had some form of abdominal surgery, as evidenced by the prominent sutures that can be observed. I do want to emphasize that the amount of Camper's fascia can be significant. Here, it's a corpulent cadaver in which the fatty, superficial fascia was several inches deep. In general, expect to find from half to 1 inch of fat in most cadavers. One way to truly appreciate the layers of the abdomen is to perform a horizontal section through the abdomen and view the anterior abdominal wall in cross-section, as is being done in this dissection. In this image, the following layers can be more easily made out: skin, superficial fascia of Camper's, superficial fascia of scarpus, and yes, we can see several muscle layers, the muscles of the anterior abdominal wall, and we will discuss this now. And if you're wondering if this is a piece of fresh bacon, it is not, although it does resemble one. Indeed, bacon is nothing more than the layers of the pork belly, the corresponding anterior abdominal wall, similar to what I am showing you here. Let's start describing the muscles of the anterior abdominal wall by first mentioning the external oblique muscle, just deep to the superficial fascia. The external oblique takes its origin from the lower 8 ribs and interdigitates with the lower fibers of the serratus anterior muscle. The muscle extends inferiorly in an oblique fashion and see how its fibers are oriented similarly to how you put your hands in your pockets. One insertion of the fibers is the iliac crest, but unlike other tendons, the medial portion of the tendon becomes broad and is called an aponeurosis. This aponeurosis will meet the aponeurosis of the contralateral external oblique muscle and form a sheath, the rectus sheath. The thick lower border of the aponeurosis represents the inguinal ligament. Not clearly visible from this angle, but we will discuss this ligament in greater detail in another lecture. Looking now at the cadaver from its anterior view, I can show you the anterior rectus sheath formed from the aponeuroses of the right and left external muscles. The aponeurosis of the left external oblique is clearly evident. Also, from this view, the inguinal ligament becomes more visible. The inguinal ligament extends from the anterior superior iliac spine, ASIS for short, to the pubic tubercle. Reflecting the external oblique muscle on the left side reveals the internal oblique muscle. Part of the external oblique muscle is still present. Note how the fibers of the internal oblique muscle run perpendicular to those of the external oblique muscle. If you're wondering in your own dissection whether you have separated the muscles at the correct plane, simply follow the orientation of the fibers to get your answer. The internal oblique originates from the lateral portion of the inguinal ligament and attaches to the contralateral side via its own aponeurosis. The aponeurosis of the internal oblique also contributes to the rectus sheath. Cutting and removing the anterior rectus sheath formed by the aponeurosis of the internal and external oblique muscles reveals another muscle, the rectus abdominis. This is the muscle that can give us the six-pack if we exercise it. Given that I'm now demonstrating a female cadaver, let's label some structures that we described previously for orientation. Here, for example, are the muscle fibers of the external oblique muscle. Here's the corresponding aponeurosis, and here we see the muscle fibers of the internal oblique muscle. Finally, here's the corresponding aponeurosis. Continuing to reflect the anterior rectus sheath exposes the rectus abdominis in its entirety. We again label structures we have seen previously: the external oblique muscle, the internal oblique muscle, and the reflected rectus sheath. Now focus on the white horizontal lines interposed in the rectus abdominis. These are the tendinous insertions of the rectus abdominis, and yes, they can be prominent when possessing a decent six-pack. However, they're also clinically relevant. First, they help attach the muscle to the sheath. Also, the rectus abdominis is the only muscle whose fibers can be transected in the vertical plane without causing complete denervation of either the right or left rectus abdominis. Only the portion bound by the intertendons distal to the incision could be impacted. This is because each section defined by the intertendon is its own muscle. Each section is arranged in a series to create a rectus abdominis as we know it. This is not to say that an incision should be made on each individual muscle section and that the muscle will be fine. In general, these incisions are mistakes done when trying to open up the abdomen in an emergency situation. But if one section is cut, the remaining muscles in series are fine. In contrast, a vertical cut on the obliques, anterior versus abdominis, is more likely to involve several myotomes and compromise the integrity of the anterior abdominal wall. Now focus on the midline portion of the cadaver, the area termed the linea alba. This area represents a seam where the right and left rectus sheaths meet. Hence, it can be considered an insertion point for both the right and left rectus abdominis muscles, since the linea alba is part of their aponeuroses. An important clinical note to remember is that no major nerve or vessel crosses the midline of the anterior abdominal wall. Hence, the linea alba is frequently used as a site for surgical incisions. I remind you of a previous cadaver where the suture line followed the linea alba. Looking at a different cadaver, again with the rectus abdominis exposed, let me label the structures we're familiar with. The muscle fibers of the external oblique and internal oblique muscles, the remaining anterior rectus sheath, the cut edge of the anterior rectus sheath, and the right and left rectus abdominis muscles. But in addition, two little muscles now appear, the pyramidalis muscles, not present in all cadavers. The pyramidalis muscles tense the linea alba. The muscle usually contracts together with the other abdominis muscles, contributing to contracting the abdominal wall and increasing the positive abdominal pressure. We will add some more information in this regard shortly. I have now switched to another cadaver to demonstrate the last muscle of the anterior abdominal wall, the transversus abdominis muscle. This muscle lies deep to the internal abdominal muscle that needed to be reflected to reveal the transversus abdominis muscle. The transversus abdominis also attaches to the contralateral side muscles via an aponeurosis, which is now labeled the posterior rectus sheath. The posterior rectus sheath, unlike the anterior rectus sheath, ends before reaching the pubic bone, and this termination is called the arcuate line. The location of this termination is approximately midway between the umbilicus and the pubic symphysis. Interestingly, it is here where the blood supply enters the inferior aspect of the rectus sheath. This artery is known as the inferior epigastric artery. We will need to learn more about this artery shortly. Once again, let me show you the transverse anterior abdominal wall, and now we can finish labeling the layers of the wall we mentioned earlier, including the muscles. Initially, we described the skin, the superficial fascia consisting of campers and scarpas. I've now described the external oblique muscle, the internal oblique muscle, the transversus abdominis muscle, and the rectus abdominis muscle containing the rectus sheath, consisting of the anterior and posterior rectus sheath. Realize that each side of the body expresses a rectus sheath, and the two sheaths meet in the midline. This line is referred to as the linea alba. And remember, it is of clinical relevance. Nerves and vessels do not cross the midline and are not found here. You will see how surgeons exploit this fact shortly. We can also now label another layer of fascia, the fascia transversalis, that lies deep to the transversus abdominis, the extraperitoneal fat that is deep to the fascia transversalis, and finally the peritoneal membrane. If this membrane is pierced, we enter the abdominal cavity proper. As to the function of these muscles that I have just described, they're listed here. They form a strong expandable support for the anterolateral abdominal wall. They protect the abdominal viscera from injury. Think of a boxer being pounded in his abdomen. They compress the abdominal content. Think labor and giving birth. Push, push. These are the muscles used. They help to maintain or increase the intra-abdominal pressure and, in so doing, oppose the diaphragm and produce expiration. And finally, they move the trunk and help to maintain posture. Indeed, poor abdominals are often the main cause of back pain. Let's now begin a brief discussion of vessels and nerves that serve the anterior abdominal wall. On the left, we see the anterior view of an anterior abdominal wall partially dissected. The left rectus abdominis has been reflected to expose the posterior rectus sheath. As we mentioned previously, the posterior rectus sheath does not end at the pelvis, but somewhere between the umbilicus and the pubic bone, at the arcuate line. You can see the extraperitoneal fat just deep to the posterior sheath. It is at this point that the inferior epigastric artery enters the posterior sheath to supply arterial blood supply from below. Moving to the dissection on the right panel, we look at the rectus abdominis and the posterior sheath from behind. The complete anterior rectus sheath has been reflected anteriorly. Note that the posterior rectus sheath covers only part of the rectus abdominis muscle. The sheath ends at the arcuate line. It is here that the inferior epigastric artery and vein enter the sheath. It should be emphasized, however, that the inferior epigastric artery is not the sole arterial supply of the rectus sheath. Recall that in the thorax, we studied the superior epigastric artery, a terminal branch of the internal thoracic artery. Of clinical relevance, the inferior and superior epigastric arteries form a functional anastomosis. When the aortic arch is narrowed, just beyond the origin of the left subclavian artery, a condition known as coarctation of the aorta, sufficient arterial blood may still reach the lower part of the body through anastomoses between superior and inferior epigastric arteries. Also, the paths of these arteries are important to appreciate while performing surgeries. For example, trocar placement in laparoscopic surgery, percutaneous endoscopy gastroscopy tube placement, inguinal hernia repair, paracentesis, and drain placement during cardiothoracic surgery. Indeed, in breast reconstruction, where the rectus abdominis is used, the inferior epigastric artery can be cut and the muscle, now being used for reconstruction purposes as a flap, receives its blood supply solely from the superior epigastric artery. With respect to the identical system of veins, the arteries have now been colorized to represent the corresponding veins. An obstruction of the superior vena cava, perhaps as the result of compression by a tumor, blood from the head, neck, and upper limbs can reach the right atrium via the inferior vena cava through anastomosis provided by the brachiocephalic, internal thoracic, superior epigastric, external iliac, and common iliac veins. Blood would flow in the reverse direction in the same venous channels in an obstruction of the inferior vena cava. Blood within valve veins can reverse direction if the veins become distended to such a degree that the valves are rendered incompetent. Moving now to the lymphatic drainage of the anterior abdominal wall, it is quite straightforward. Any superficial lymph above the umbilicus drains to the corresponding axillary lymph nodes. Moving now to the lymphatic drainage of the anterior abdominal wall, it is quite straightforward. Any superficial lymph above the umbilicus drains to the corresponding axillary lymph nodes. Any lymph below the umbilicus drains to the superficial inguinal lymph nodes. For now, this is the extent that you need to understand the lymphatic drainage of the anterior abdominal wall. Moving to the nerves, here I show you the external oblique muscle in which nerves are drawn in. These nerves are the ventral rami of spinal nerves T7 to T11, which continue from the thorax into the anterior abdominal wall. The subcostal nerve, or T12, also makes it to the anterior abdominal wall, as well as the ventral ramus of spinal nerve, L1, which is usually first found emerging from the superficial inguinal ring. L1 will likely split into an iliohypogastric and an ilioinguinal nerve. One way to remember this nerve is to focus on T10, the nerve that travels to the umbilicus. This will become even more clinically relevant when we discuss referred pain. There are 3 nerves above T10 and 3 below. If you now look at the right panel of the image, you can again see the ilioinguinal nerve. In this dissection, the external oblique muscle has been reflected, exposing the internal oblique muscle to demonstrate that all these nerves course between the internal abdominal oblique and the transversus abdominis muscles. The nerves provide innervation to the external and internal obliques and the transversus abdominis muscles. Ultimately, these nerves will pierce the rectus sheath and innervate the rectus abdominis. I should mention that the nerves shown on the left panel are the cutaneous nerves of the anterior abdominal nerves. The motor branches, as already mentioned, run in between the internal oblique and the transversus abdominis. Similarly, the nerve branches that pierce the rectus sheath will emerge as anterior cutaneous branches. Indeed, the ilioinguinal nerve is the principal example of this pathway, given that at the point it is being shown, it is strictly a cutaneous nerve. And by the way, the same situation exists in the female. Having described the makeup of the anterior abdominal wall, let's identify the classic surgical incisions used to enter the abdominal cavity via the anterior abdominal wall. These incisions include the following: the subcostal, the right paramedian, the gridiron, muscle splitting, the median, the transverse, and the phalansteal or suprapubic or bikini cut as it became known in the vernacular. The rationale for entering the abdominal cavity and why an incision is made are listed here. I will not read them to you. They are not required for this course. If you wish, you can stop the movie and read them to gain some perspective on abdominal surgery. Also, in a separate video, not required for this course, strictly for enrichment, I have prepared a short explanation for each surgical incision, specifically their use. This now concludes this lecture on the anterior abdominal wall. Let's start describing the muscles of the anterior abdominal wall by first mentioning the external oblique muscle, just deep to the superficial fascia. The external oblique takes its origin from the lower 8 ribs and interdigitates with the lower fibers of the serratus anterior muscle. The muscle extends inferiorly in an oblique fashion, and see how its fibers are oriented similarly to how you put your hands in your pockets. One insertion of the fibers is the iliac crest, but unlike other tendons, the medial portion of the tendon becomes broad and is called an aponeurosis. This aponeurosis will meet the aponeurosis of the contralateral external oblique muscle and form a sheath, the rectus sheath. The thick lower border of the aponeurosis represents the inguinal ligament. Not clearly visible from this angle, but we will discuss this ligament in greater detail in another lecture.